Hi, I'm Heather. I'm a senior medical resident at McMaster University. This rapid refresher video will describe a practical approach to syncope. This refresher is targeted to independently practicing physicians who are returning to general internal medicine and who want to brush up on their knowledge. This is not meant to serve as general medical advice to the general population. Syncope is defined as a transient loss of consciousness caused by global cerebral hypoperfusion. It has a rapid onset, a short duration, and spontaneous recovery without neurologic deficits. Step 1 when assessing a patient who presents with loss of consciousness is to consider symptoms that may mimic syncope and rule them out where possible. Mimickers include conditions with a loss of consciousness, but where the loss of consciousness is due to a metabolic or structural abnormality rather than global cerebral hypoperfusion. This occurs in the case of seizures, hypoglycemia, hypoxia, hyperventilation with hypocapnia, and intoxication. Mimickers also include conditions that are not associated with a loss of consciousness, but which occur suddenly, such as the fall or psychogenic pseudosyncope. Once these mimickers are ruled out, causes of true syncope can be divided into two major categories, cardiac and non-cardiac. In order to get an accurate history of the syncopal event, the following questions should be asked. What happened leading up to the syncopal event? Were there any triggers? Were there any prodromal symptoms? What happened during the syncopal event, especially if there were witnesses around? Was there seizure-like activity? Was there incontinence or tongue biting? Finally, what happened after the patient regained consciousness? Were they alert and oriented immediately, or was there a period of drowsiness suggesting a possible post-ictal state? After gathering a comprehensive history, you need to consider features suggestive of a cardiac cause of syncope. Cardiac syncope can be further divided into electrical and structural causes. Electrical causes include tachyarrhythmias, such as ventricular tachycardia, or bradyarrhythmias, such as complete heart block. Structural causes include severe aortic stenosis, mitral stenosis, dilated cardiomyopathy, or hypertrophic obstructive cardiomyopathy. Red flags on history which may point to a cardiac cause of syncope are 1. Cardiac prodrome, for example, chest pain or shortness of breath or palpitations. 2. Syncope which occurs during exertion. 3. Lack of prodrome entirely. 4. A history of heart disease. Or 5. A family history of unexplained syncope or sudden death. Non-cardiac or non-cardiogenic syncope can be divided into neurocardiogenic, orthostatic, or vascular etiologies. Neurocardiogenic causes of syncope include vasovagal, situational, such as during urination or defecation, or carotid sinus stimulation, related syncope. To further delineate these etiologies, a careful history is very important. For example, vasovagal syncope tends to have a prodrome, has a quick recovery, and no neurologic sequelae. It may be associated with crowded spaces, prolonged standing, or emotional stress. Orthostatic syncope can be due to many underlying issues such as volume depletion, vasodilators or antihypertensives, dysautonomia, and it should be associated with positional changes. In terms of vascular etiologies of syncope, pulmonary embolism should always be on the initial differential. When conducting a physical examination for syncope, you should always get vitals first. While getting vitals, make sure to also get orthostatic vitals in all syncopal patients. If the patient's heart rate increases by more than 30, if their systolic blood pressure decreases by more than 20, or if their diastolic blood pressure decreases by more than 10, or they become lightheaded within 3 minutes of standing, they have orthostatic hypotension. Other important physical examination maneuvers to complete to assess for a cardiac cause of syncope include listening for abnormal heart sounds or murmurs. Make sure to assess for any signs of venous thromboembolism, suggesting a possible pulmonary embolism, such as unilateral leg swelling, pain, or erythema. Finally, it's also important to complete a neurologic exam, as any new focal neurologic deficits would point you towards investigating for stroke or seizure. In terms of ordering investigations for a patient with syncope, to assess for cardiac syncope, make sure to get an ECG. Look for any signs of an underlying arrhythmia and look for widening of the QRS complex, PR prolongation, an abnormal axis, or a prolonged QT interval. Using the information gathered during the history, physical examination, and by looking at the ECG, you can use the Canadian Syncope Risk Score to risk stratify patients and determine whether the patient is at high risk for a serious adverse event within the next 30 days. This risk score is validated for patients presenting to the emergency department with syncope. You should also get a basic blood work panel, including a CBC, electrolytes, a capillary blood glucose, and a creatinine to assess for any metabolic disturbances that may be contributing to the patient's presentation. A troponin is also often needed, particularly if the patient presents with any chest pain or dyspnea with their syncopal episode. The remainder of the blood work should be based on the history and the physical examination. If the patient is low risk according to the Canadian Syncope Risk Score, and there are no other concerning features on history, physical examination, or investigations, they can likely be discharged home with no further workup. However, if they are medium to high risk, they will likely require a hospital admission for further workup. This workup should be based on the history and physical exam, but may include an echocardiogram or cardiac monitoring. Depending on the most likely cause of the syncopal event, based on history, physical, and investigations, the patient may also be sent for tilt table testing in the case of orthostatic hypotension, an electrophysiologic study in the case of arrhythmia-related cardiac syncope, or an EEG in the case of possible seizures. The following driving guidelines are based on the Canadian Cardiovascular Society 2003 Consensus Statement. If you are practicing elsewhere, you will need to consider your local laws and regulations. After a single vasovagal syncopal event, the patient can continue to drive if the event did not occur while seated. If the patient has recurrent or unexplained syncope, you will need to file a report to the Ministry of Transportation, and the patient will be unable to drive until they are syncope-free for 3 months in the case of private drivers, or 12 months in the case of commercial drivers. I'd like to thank my co-author, Dr. Akbar Panju from Internal Medicine. The resources used during the creation of this rapid refresher video were the McMaster Textbook of Internal Medicine 2019-2020, the Intern at Work podcast and infographics, the Canadian Syncope Risk Score, and the Canadian Cardiovascular Society 2003 Consensus Statement regarding driving. All links to these resources will be posted on the website. Thank you for watching this rapid refresher video on syncope.